Hello, I'm Dr. Shlomit Schaal. Welcome to Women in Surgery, where I get to speak with the leading voices in medicine. All of them just happen to be women. And today joining me is Dr. Barbara Bass. She is the Dean of George Washington University School of Medicine and Health Sciences. She is the Vice President of Health Affairs of the university and Professor of Surgery. Welcome, Dr. Barbara Bass.
Hi, Dr. Schaal. Thank you for having me. I'm delighted to be here.
I've heard so many great things about you. I started actually after you already were promoted to this current role. Please tell us about yourself a little bit.
My story begins as a native as a person from the Washington, D.C. area, fundamentally. And I went to medical school at University of Virginia. And I started there in 1975. And so I will say, and I keep thinking of that right now, because as I greeted my new class of medical students this year at GW, the class of 2029, it occurred to me that was 50 years ago.
Wow.
So it really has been an astonishing ride over these last 50 years. Went to University of Virginia, and then I came and trained here at George Washington University for many reasons. One of which was that's where my husband was in law school. So that was a driver you'll see throughout my career. Maintaining home and family has been an important consideration for me. But also at University of Virginia, I was introduced by virtue of one of the faculty members there to a really pillar of academic medicine in those days, Dr. Catherine Anderson, one of the few women in surgery who happened to be, at that point, really a relatively young surgeon at Children's Hospital here in Washington, D.C. And that was enough to sort of convince me that coming here to GW was a good choice for me. I trained here in general surgery and under the mentorship of Dr. Paul Shorb and Dr. Catherine Anderson and others. And at that time had the chance to, I went into surgery knowing I wanted to be an academic surgeon. I had great mentorship here at GW, but I knew I wanted to be an academic. And so at that point in those early days, at the really terrific programs, people would leave to go do research fellowships that would prepare them for their future career as a clinician scientist, which was my aspiration. I also was very interested in pediatric surgery at the time, and that was sort of a rite of passage and still is in terms of being a successful candidate for that. But I also knew I had to be here in Washington, D.C., and the best surgical research job at that time in this country, in this nation's capital, was in fact at Walter Reed Army Institute of Research. And the only trouble with that was to get that job, I had to join the Army. So I joined the Army and was a captain in the medical corps. It was one of the most outstanding experiences of my life. I am so grateful for those years of service. Both in understanding what the military service and especially the healthcare elements of it, but all of our service members do for us. And it was an astonishing time for me. So I learned all about how to be an officer and how to help and understand the enlisted people who are our military services. And it was great value to me in my subsequent years as a VA surgeon for many years as well. So it was a great introduction to that world of academic surgery. I had great mentorship and then came back and finished my training. During that time, I had my first son, and there were many who thought when I left to go to do research, well, that's the end of her. I would never come back from this. And it did, however, put an end to my career in pediatric surgery because I lost my edge in taking care of sick babies. I can't see a baby with an IV now without breaking up. So it did change my career path. And I did become an academic surgeon, primarily in gastrointestinal surgery and mainly surgical oncology over the course of my career. I will say that I had probably close to 30 years of my career. I was a funded clinician scientist, either doing discovery research for the first 20 years or so with VA and NIH funding and wonderful team partnerships with gastroenterologists and GI physiologists and all those things. And then later, especially during the mighty years, transitioning to work with computational scientists and engineers as the landscape of what defines advances in surgery evolved. And that was during my Methodist years as well. So anyway, so I did that, and I had my early career as a clinician scientist and a wonderful practice with complex GI surgery primarily, but I was a good old-fashioned general surgeon. So I did endocrine, I did breast, and eventually, honed in on a couple of areas in oncology that became my home. And then I spent about a decade as well at the University of Maryland as vice chair, and that's where I got my grounding in surgical education as a really core part of my I'm going to say professional responsibility and identity. Became a program director, of course. That was kind of my major thrust, I'm going to say, through the course of my career. And it became a very visible one. I wasn't really ever looking for visibility, but at that point, if you're a young surgeon that's doing those things, you kind of stand out because there were only a handful of us that had risen through the academic ranks and that were holding those kind of positions at that time.
Inspiring story, and we stopped at kind of half of it before you became chair. But let's unpack a little bit about the steps that you went through, and you started with really a residency program during the 70s, a long time ago. A long time ago. I think the residency programs back then probably looked different for everyone. And, now you're serving as a dean, you're responsible for ultimately all residency programs. What can you tell us about the major changes from those times till today, the emphasis and progress that we have made throughout these, last almost 50 years?
Almost 50 years. Oh, boy. Well, I think there's been an infinite number of I'm going to say, improvements along the way. There was no question that when I started my training, like many others of my era, we lived in the hospital more or less. I have 2 years of my life. I don't remember anything other than being in the hospital.
That's why it's called residency, right? You were a resident.
I don't remember anything, I was having a great time. I mean, I was learning to be a surgeon that I had never imagined being a surgeon, but I discovered I was one during my training, during my medical school years. And so that was exciting to learn to do all that thing, but you did give up a lot to do that. And certainly I would say that during that era, women gave up more than men for the most part. It was very difficult to have a family in those days. It was very difficult there were much higher rates of attrition for women than men from surgery programs in those days. To this day, there's still a little bit of a difference in those that finish their training for a myriad of reasons, but I will say it's not because they're not smart enough or not because they don't work hard enough. It's because of all the other things that come into being completing a surgical training, that some of which is personal, some of which is external, some of which is intrinsic to some of our programs still. So we still have a ways to go relative to creating that true equitable opportunity for women, for people of color, for international graduates, I'm going to say too as well. Certainly as the change in medical school enrollment has shifted to reflect really near equal proportions of men and women in medical schools these days, women are more and more seeking, as you did in ophthalmology, careers and disciplines that historically were preserved for men for all those many reasons that we really don't need to go into. And in quote general surgery, now it's close to 45% of the entering residents are going to be women, and that's a huge shift. Along with that, though, in training, we've seen real substantial changes relative to what we call the working environment, the learning environment. No question, the work hour restrictions, I'm going to say modifications, improvements, allowed our residents to live at least some of their lives more fully. Starting, that was about 2000 or so. So we've seen that adaptation. You'll still find some people that push back on that, but hey, it really made for happier, healthier residencies and residency programs. I have no doubt.
Did it contribute to less attrition? You said that back then there was
It has not specifically contributed to less attrition. General surgery still has a wave of people that will migrate into other disciplines. And I think that just reflects the heterogeneity of what general surgery is. And people recognize that, oh, I'd rather be a plastic surgeon and get there in the third year. I'm okay with that, you know. And general surgery, of course, now includes has developed, and I'll take some credit for some of that. Many of the pathway, this is another way in surgical training is changing. We recognized that general surgery as a discipline is actually a hodgepodge of multiple disciplines. And you don't necessarily have to have that full platform to be a really good vascular surgeon or to be a really good cardiac surgeon or a plastic surgeon. So we've developed more differentiated training pathways for people that I think are both efficient and improvements. And as past chair of the American Board of Surgery, during the time when we were developing those pathways, I think we've made training more efficient, better, and more focused. And that's a good thing. The other thing we've done is really we've been more explicit about what are we've brought much more structure to our training programs in terms of required experience, operative experience, and now entrustable professional activities. I mean, we brought real principles and structure and appraisal, as well as support to our programs, which I think really has benefited our trainees in a very positive way. It's still a long grind. It's still hard. But I think it should be fun. I hope it's been fun. And I think we've done a lot of faculty development as well. You know, I think it's really important because the environment in which our trainees work now, it's a focus that both the RRC, the ACGME, and of course the LCME, the accrediting body for medical schools, pays a lot of attention to that environment so that we can create a learning environment that is supportive of individuals and lets them be their best person without getting the old-fashioned kind of hard love kind of learning environment. Doesn't help many people really. But in my world of surgery, I think the big change has been the introduction of simulation-based learning, assessment, retooling, and new technologies that has really transformed how we safely can adopt new technologies. If I take credit for one thing in my life, it's going to be that notion of, and I can't really take credit for it, obviously, but I mean, I think one of the things that really drove me during my career was having grown up in the open surgery era. I did everything with my fingers. I cut big holes. I touched things. I used my hands to do things. Was that technological introduction of a device between my hands and that patient's disease? To this day, probably the best site for retooling, and I'm talking about physicians in practice to come and learn about a new technology, a new interface between their hands, a new minimally invasive image-guided computer-aided procedure is based on the MIghty model. That really is where it all began. And there are different sites that have done different pieces of it, but to consolidate that into a center that is specifically focused, not just, on retooling the workforce that right now doesn't have access to that infrastructure unless they, maybe a company will help you sometimes. Maybe you can go visit somebody a little bit, but to have a place that has structured education with real live technology, real live education metrics for a person in practice, that's a big deal.
But what is MIghty for those of us who don't know what that is?
Oh, okay. I'm sorry. Yeah, MIghty. Okay, the Methodist Institute for Technology, Innovation, and Education. I presume it's still called that. It certainly was when I left. And it's a magnificent, about 40,000 square foot facility that has all of the technologies present, coupled to a sophisticated educational infrastructure that provides brief, and I'm going to focus just on this part first, brief retooling experiences for surgeons and proceduralists in practice as they seek to safely acquire new technologies into their procedural repertoire. It's done with partnership of industries, those who have the tools. It's done with a lot of the faculty, of course, at Houston Methodist. We've partnered with a variety of fellowship organizations and surgical organizations to really really create a space where you can come and get that retooling.
Is it more difficult to be trained as a surgeon today with all these kind of instruments between you and the patient, or is it easier?
Yeah, it's a good question. I haven't lived through that myself. Surgical training has evolved to meet the needs of our surgical patients. So now, if you're a general surgeon, you're more comfortable doing a laparoscopic or a robotic procedure than you are an open procedure, because that really is what's best for our surgeons in most of our environments where we practice. And so you get to practice and learn on the devices, and I think it's probably very comparable. I can't say it's easier or harder. It's just different. And I bet you it's certainly adequate, and I bet it's the same.
So you talked a lot about the residency environment and, gave us some hints of how it has evolved. Better environment for both our surgeons, our learners, and our patients, of course. And then I am curious, this is the technical skills, but you are a clinician scientist, which is another area. So the academic medicine. And still, if we have to look at all our faculty members, anywhere in the nation, in the world, there are more academicians in non-surgical areas than academicians in surgical areas. So, from your experience, how did you get into the academic, clinician scientist path? And then how do we really evolve that and give the opportunity for future generation to follow your footsteps and others?
Yeah, I think we have to remember that I finished my training almost 40 years ago, and things were different then. The thing that we prized and valued was, in fact, discovery science, translatable discovery science as a young academic surgeon or a young academic physician of any ilk. That was the coin of the realm. We really didn't have these other areas of mature investigation, except for clinical trials, which came along even a bit later. I mean, clinical trials are a relatively recent phenomena as well. So I think we need to be broader in our expectation for what is important science in healthcare. It's anything that improves our ability to take care of our patients better, as opposed to just that basic science piece, which is really hard. And really these days is probably best done in partnerships and dyads with clinicians and full-time PhD basic scientists. It's hard.
Yes. And you mentioned you went to Walter Reed, and that was the best research position. Talk to me. I don't know if you know, I'm also an Army officer, actually Navy officer in the Israeli Navy, and I served as a physician and an officer a part of my career. But the research part is interesting. So do we have still opportunities for our physicians to go and embark on these tracks? Are they still available for our physicians to embark on, even if it means that you have to have an Army training?
Yes. Well, I mean, there's many, many places for physicians to get their research training. And most of the time, of course, it's embedded in an academic medical center like Methodist, or like my George Washington University, or the other programs that we all would have name brand recognition of, a place that, delivers that most substantial body of advancing biomedical research, translation, etc. But the Army and the armed services in general still in this country have several research institutes. Down in San Antonio, as a matter of fact, at Brook, there's one, and certainly Walter Reed still exists, and there's one out in San Francisco as well, that are really, really core mission. They do, for the most part, study the conditions that are pertinent to war injury. That's kind of what they do. These programs are small relative to the NIH or to the major academic medical centers that live in partnership with the NIH, but the DoD still sponsors substantial discovery and clinical translational research. Some done at those host sites and some done in partnerships. For example, at Methodist, I know there were many DoD funded projects, even in things such as breast cancer. it's still part of the way to improve the health of our troops and secondarily, therefore, our public.
Let me ask you about leadership. Obviously, you talked about being kind of one of the few women in surgery at that time, and then elevating to a role of a program director, vice chair, then chair, now dean. What advice do you have for younger female physicians who might be watching us today?
I always say that, you're never going to go anywhere unless you walk through a door when it opens, and sometimes that's scary. Sometimes that's not a good idea, but generally it's a good idea, and I think that stepping into opportunities is a very, very important thing. I will also say that in my time, and I would say for anybody going forward, that mentorship and sort of doing that ally building, I don't think I intentionally did ally building, but it did happen a lot. And I really did benefit from the guidance that I received from people I had never actually worked with, were the chair of I don't want to even name the list because it's such a wonderful list of chairs of very important programs, very important leading academic programs, most of them GI surgeons, that adopted me and helped navigate me through these things. It was amazing. And especially throughout my career. And the other thing I think is that you got to be careful. You can't overdo it. But I had many people who wanted me to become more visible. So, participating in organizations like the American Board of Surgery, and then all of a sudden you're the chair of the American Board. That's a lot of influence. Being at the table is really important. And then, when other people started becoming chairs that were about my age, I looked around and said, what is he doing? He's a chair. And so I started looking at that, and I was offered a couple of regular old chair jobs. And I thought it felt like they were stuck in the mud. And then came this job at the Methodist Hospital back then in this new affiliation with Weill Cornell at the time. I can assure you that there were, and I will credit Tony Gatto, who was the then dean, for calling me up and saying, Barbara, I got a great job for you. And I said, that sounds like a pretty wacko job. And then I came down and visited several times and met John Bookout. And it was an exciting job because it was a blank slate in a magnificent clinical enterprise with incredible leadership that had a clear vision as to where this place was going to go. That fit me like a glove. My point here is to say you have to know yourself in terms of what punches your buttons, what makes you want to step into an opportunity. And it's not about, climbing ranks and stuff. It's like what excites you and what can you contribute to? And then I also believe in blossoming where you're planted. So once you get there, man, go for it. It's really fun.
So it sounds like you had a great time of leading the Department of Surgery here at Houston Methodist. So you became dean. Why? How did that happen?
Well,
and then what excites you about your current job?
Yeah, my current job is exciting as well. It really is. And I think this is the other thing about our careers. You want to keep doing things that are where you're going to keep learning. You're going to keep learning new skills and facing new challenges. I'll be honest in saying that my family is here in the area. My children, my grandchildren, they were pretty important to get back to. And so a return to the East Coast was pretty important for me. And plus I had roots here at GW as having trained here. So there's a bit of the giving back piece here. And the excitement of doing something new and learning about how to lead an academic medical enterprise. And they're all different, but this has been a great learning experience. The only thing that I didn't count on was COVID, which of course struck right after I started. And there's been many sequelae since then. It's been a very challenging job, but boy, have I learned a lot. And boy, have I learned to love my faculty. We have incredible clinicians and basic scientists, and I've learned a lot about PA studies and PT and OT, and I've learned a lot about undergraduate medical education, which I'll be honest, and I told people when I took this job, I don't know about that stuff. I know a lot about GME, but I don't know much about undergrad. I've learned so much, and that's been fun, So we face challenges every day, and as the academic medicine challenges and medicine and money are a constant challenge, but if you can stick to what are your core missions, you're going to you're going to train the next generation of surgeons and of physicians and PAs and scientists. We have a wonderful group of basic science departments here that are doing fabulous work in cancer and neuroscience and HIV. And so if you can we're going to train that next generation. We're going to do the research that advances care. It's going to make life better for everybody. That's pretty cool. You're going to build a cohort that does wonderful clinical care. Who doesn't like that, And you're going to do it in a way that advances care and innovates, and hopefully in an environment that fosters the wellness of our physicians, of our students, of our nurses, of everybody, try to get that little positive thing going, although I'll tell you it's really hard in these days. And then last, how do we serve our community best? And I'm right here at a job. My office is 6 blocks from the White House. I'm 1 mile from Capitol Hill. We have an incredible opportunity in terms of policy and interaction with the House of Politics, or whatever we want to call it. But policy, we have real influence in policy right here. It's been fascinating. It's been exciting. And it's been difficult, but if things are easy, who wants to do something that's easy, So, but it's been fun.
Nothing about your journey was easy. Just leave us with some thoughts about the future of academic medicine or academic surgery. What is your gut feeling? How are we going to progress over the next 5, 10, or 15 years?
Yeah, boy. Well, I think the good news in academic medicine is we're always going to need new physicians. I do believe that. We're always going to need new PAs. We're always going to need new scientists. And I think the trick for us will be to figure out how do we get them all to work together and really optimize the care delivery teams we have that will facilitate innovation, new products, safe implementation. There's so many things to do. I think in terms of the practice of medicine, we're going to see, increasing expansion of networks and hopefully quality-driven care that is patient-focused, patient-centered. And, I hope we can train a workforce that really, really understands and believes that. And as part of that, creating that future. It's going to be different. It's going to be exciting. And don't mention AI and technology, because boy, is that ever going to, impact all of us in a way that my brain's not going to be ready for. So I'm going to have to retire before that.
Dr. Barbara Bass, it was absolutely a pleasure to talk to you today. Thank you so much for your time. And thank you for listening to another episode of Women in Surgery. We'll see you next time.